correlative studies that were done actually in monkey, you can actually see we compared the responses of primary afferent neurons, C fibers, as well as these nociceptive A fibers to this kind of mechanical stimulus. And what you see is that the A fibers actually show a dose-response curve similar to what the pain ratings in subjects look like, whereas the C fibers, they saturate already at very low intensities. Basically, together these results argue that A fiber nociceptors signal the sharp pain to mechanical stimuli. What about chemical stimuli? One of the ingredients that we use in our research is capsaicin. Hey, hello. Sure. Theory, yes, in practice, no. And the reason why I say this is that these type of block experiments are very difficult. The advantage of these block experiments in adult people is you can really ask them what their sensation is. So you have to track the block by asking if they, for example, detect touch stimuli, cold stimuli, if they detect warmth, yes or no. That's how we track how this stimulus, how this block is actually active. In a neonate, this would not be doable. So we need the input from the subjects to tell us what their sensation is at different points during the block. So with that, so how do we sense chemical pain? And one of the stimuli that we use in our laboratory is actually capsaicin. If you inject capsaicin in different doses into the skin, you actually get an increase, a sharp, very sharp burning pain that increases with the dose and for long lasting over 10, 15, 20 minutes depending on dose. And I just want to show an example from a mechanoinsensitive C fiber responding to the application, to the injection of the capsaicin. You can see that we get, with the onset of with the injection, we get a sharp peak in activity, and then during the rest of the 10-minute period, we get a waxing and waning activity. And these mechanoinsensitive C fibers act most likely as chemonociceptors. So these classical polymodonociceptors, while they respond to chemical stimuli, usually their response is poor when compared to these mechanoinsensitive nociceptors. Good, so this is basically the basis for nociception in the periphery. However, this changes when we have an insult to our skin. And as Michael has already pointed out, when you have, for example, a sunburn, suddenly stimuli that were not perceived as painful previously become painful. And if you look at the dose-response function shown here on the right, under normal conditions, you have a stimulus-response function here shown in blue, where you have to reach a certain threshold, and when you cross that threshold, you get pain sensation, and when you increase the stimulus further, the magnitude of pain increases as well. Now, after sunburn, this stimulus response function is actually shifted to the left, and that is termed hyperalgesia, and as a consequence of hyperalgesia, now stimuli that previously were not painful become painful, and secondly, stimuli that were previously barely painful become very painful. This is what we understand under hyperalgesia, and the big question is, what are the mechanisms, the neuronal mechanisms underlying the hyperalgesia? And what we know is that there are, from psychophysical experiments in humans again, that there are two zones of hyperalgesia. At the site of the injury, that's what we call the primary zone, we see that we have hyperalgesia to heat stimuli as well as to mechanical stimuli. So for both of these stimulus modalities, the stimulus response function is shifted to the left. In addition to the primary zone, we have a large secondary zone. That is basically skin surrounding the injury site, but it's not injured by itself. And from that secondary zone, you can also detect a hyperalgesia, but this is a hyperalgesia that is largely restricted to mechanical stimuli, but not to heat stimuli. So in those areas where you inject capsaicin, or after sunburn or burn, the surrounding skin becomes very sensitive to mechanical stimuli. So what actually serves, what are the neuronal mechanisms that serve these two forms of hyperalgesia? One of them, the primary hyperalgesia, is actually served by peripheral sensitization, and that is basically that the nociceptor underneath this injury site becomes more active, becomes more sensitive to mechanical and heat stimuli. And this is just one example here. This is the dose-response function of classical polymodal nociceptors to painful heat stimuli. Then we apply to the site that we test this like burn injury, and after the burn injury you can see that the response to the heat staircase actually is increasing. So it shows signs of peripheral sensitization. In addition, we can observe sensitization to mechanical stimuli, especially in mechano-insensitive afferents. So this is an example of a mechano-insensitive afferent where we injected a chemical soup, an inflammatory soup, and then we can see actually how this unit responds to that chemical stimulus. And after 20 minutes after the substance was injected, we retested its response to mechanical stimulus, and now you can see that this primary afferent starts to respond to the mechanical stimulus, again showing that this unit, this primary afferent nociceptor, becomes sensitized. So peripheral sensitization to thermal as well as to mechanical stimuli actually explain signs of primary hyperalgesia. Now, unfortunately or fortunately for us, peripheral sensitization does not account for signs of secondary hyperalgesia. So as I pointed already out, there are no signs of heat hyperalgesia in the secondary zone, but there is hyperalgesia to mechanical stimuli, indicating that the mechanisms underlying primary and secondary hyperalgesia must be different. And also what we do not observe is, in the receptive field of nociceptors, we do not see signs of spreading, what we call spreading sensitization. That means we can only see an increased response to mechanical or heat stimuli at the site of injury, but not at part of the receptive fields that were not injured. So the increased response function to mechanical or heat stimuli can only be induced or can only be seen at the site of injury, but not of other parts, clearly indicating that peripheral sensitization does not account for secondary hyperalgesia.